Good morning, everyone, or good afternoon, depending on when you are in the world. My name is Valentine. I'm pleased to make this introduction for you. Today's webinar will be on the different insights on excimer light 308 nanometer. This webinar will be hosted by Cecilia Flessier. So welcome, everyone. Cecilia is a well-experienced clinical manager and trainer at our company, CLARTEIS. She has a lot of experience in dermatology. She supervises a lot of clinical studies. She's our protocol advisor as well. So she's well experienced on our technology, Exciplex. If you've got any question, it's the right opportunity to reach out to her. If you've got questions, please write them in the chat. She will address them at the end of the webinar. Our company is called CLARTEIS. We are the manufacturer of Exciplex. Our company is located in the south of France. The device is 100% made in France as well. We are registered in more than 50 countries and we have devices in more than 70, meaning that we have a lot of expertise on different phototypes. So enjoy this webinar and enjoy Cecilia's presentation.
Thank you, Valentine, and hello, everyone. Good afternoon, good morning. So today we're going to speak about 308 nanometer and about phototherapy. So phototherapy, we all know that the sun has been used over the years to treat a certain pathology, but it's been very popular in the last 100 years with UVA and with UVB. So UVA has been used a lot with UVA1, UVA2, broadband UVB, and narrowband UVB. So why we have used more and more UVB over the years? Because we noticed that UVA, also sometimes associated with psoriasis, has got some side effects, especially on increasing the risk of skin cancer. So what is the mechanism of UVB? It stimulates vitamin D synthesis, modulates immune response, promotes melanogenesis, and hair follicle melanocytes migration. What is the difference between a narrowband UVB and an excimer lamp? A narrowband UVB is this big TL01 lamp that you can see in this UV chamber that you have most of the time in governmental hospital. The wavelength is maximum 311. This is very good to treat multiple lesions, but the energy is very low. So it's about 10 milliwatt per square centimeter. While an excimer is emitted by two gas, xenon and chloride. It can be a laser, it can be a lamp, and the wavelength is 308 nanometer. The energy is very high because it's a targeted treatment, so it can reach up to 100 milliwatt per square centimeters. Exciplex comes, for example, in this case, which is portable. The power is 100 milliwatt per square centimeter, and the maximum spot size is 5 by 5 square centimeters. This allows to treat big lesion in a very short time. So 308 is actually the best wavelength to treat autoimmune skin condition. It has been proven by over 250 clinical studies published so far. The main indications are shown on the screen. Of course, vitiligo, alopecia areata, psoriasis, mycosis fungoides, atopic dermatitis, but there are also plenty more conditions that can be treated by excimer that are more rare to be seen in the clinic, such as lichen planus, lichen sclerosis, pityriasis rosea, pityriasis pilaris, etc. So feel free to also make a screenshot of the screen because there are really a lot of indication actually. But today we're going to focus mainly on three indications: vitiligo, alopecia areata, and psoriasis. So vitiligo is a depigmented disorder characterized by white areas on the skin due to loss of functional melanocytes. So with excimer, we are looking to stimulate the surviving melanocytes to repigment the affected area, especially on localized patches. What is the prevalence of vitiligo? Well, we say it's around 1% all over the world. In this map, it shows that it is more present in India. To me, we need to be a little bit careful with these numbers because sometimes when it's less visible, people are not going to the doctors to make a consultation about it. And when the phototype is higher, then of course they are more concerned about it. What is the vitiligo protocol for excimer light? So as we said, we are here dealing with a targeted treatment. So we want to treat patients that have lesion on less than 10% of the body surface. In this case, we don't do MED, minimal erythemal dose. We define the first dose on the first session according to the body area. So for example, if I would treat a face, I will start the first session with 100 millijoule. So this will take me 1 second to treat the area. And then according if the patient has erythema or not, I will either increase by 50 millijoule on the next session, or I will decrease by 50 or 100 millijoule if there is too much erythema. The session frequency is 2 to 3 times per week, ideally 3 times actually. And the average number of sessions will be 20 to 30 sessions. This is of course an average. If the lesion is recent, this might be faster. And if the lesion or it's a resistant patch, it might take longer. But what is to remember is that there is no limitation in number of sessions. Well, the maximum will be 1,000 sessions per patient, but I think no one will reach this number. If you have, for example, patient with generalized vitiligo and you have a UV cabin, you can treat the patient 2 times per week with the UV cabin and only 1 time per week with the excimer on visible areas, on resistant patches. If we are dealing with segmental vitiligo, well, the response will be different according to how old is the lesion. If it's less than 6 months, then the response is very good. If it's less than a year, you still have a good response. However, if the lesion is older than a year, the response is usually poor or no response at all. The efficacy of the treatment depends on the body area. So here on the screen, I have highlighted in red the areas that are difficult to treat or where the response is quite low, and in green where we have a very good response. So actually the poor response is extremities and genitals, and good response, best response actually is on the face. Tips and tricks, ideally 3 times per week, the patient should come to the clinic to have a trigger effect. However, we know that nowadays everyone's busy and it's quite difficult to make the patient come 3 times to the clinic. However, this is ideal. And when you have a reasonable result, then we can switch to 2 times. And if there is no results, no improvement at all after 15, 20 sessions, then there is no point in continuing the treatment with excimer. So now we're going to see a protocol for resistant cases, or in case you have reached a certain plateau of repigmentation. This involves either CO2 laser or erbium or microneedling, whatever is available in the clinic. The idea here is to create microscopic channels to allow the light to penetrate better. So in the same session, you will first do your laser or your microneedling. The parameter you choose according to the brand you have in the clinic should be the lowest one. We don't want to create a thermal effect. We want to be very gentle with the vitiligo lesion. So you will first do your laser, then you will do the light, and then you will apply the topical you have prescribed to your patient. Ideally, make it work in occlusive action, ideally. So either with foot wrap or with glove or with these plastic socks that you can have. Sorry. I have some picture here on the screen. So this is a picture from Dr. Dalia Rodriguez from Mexico. So she's using this protocol for acral vitiligo that we know is very resistant. And she made the patient wear the latex glove for 2-3 hours after the session. So this is a very good protocol if you have some difficult areas to treat. This is not a standard protocol that should be applied for any vitiligo patient. Of course, including laser should not be done at every session of Eximer. So this should be done every 3 sessions. So session 1 will be only Eximer, session 2 CO2 and Eximer, session 3 Eximer, session 4 Eximer, session 5 CO2 and Eximer. This is to avoid also any risk of Koebner. So this is another example in a different body area where she has used a food wrap. So what can be combined with Eximer light? Well, the classic calcineurin inhibitor, corticoid, topical, oral, vitamin D, superoxide dismutase, exosome now is the trend. We have seen the laser, skin crafting, 5-fluorouracil, TCA, PRP, bimatoprost or lanatoprost for periorbital area. Of course, these are examples, and if you have other combination that is not written, feel free to share your experience with all of us. So I have selected 3 studies from this year that I found quite interesting about combination. So the first one is combining 308 with an erbium. And this has shown what we just discussed about that it could be a very nice trigger when you reach a plateau. So this was the main conclusion of this study, that it was a very good tool to really have a trigger of repigmenting when you have reached your plateau. The second one is a combination of 50% TCA and Eximer light. And the result was very interesting. They used TCA 50% every 2 weeks and Eximer every week. That the group using TCA and Eximer light had much better results than only Eximer. And the last one is actually a triple combination of fractional carbon dioxide laser, PRP, and they have seen that the group using PRP had very, very nice results, significantly superior efficacy, especially on resistant acral areas. So this was very interesting to me because PRP in this type of pathology, it's the first time I'm hearing that type of study. So it's maybe a good tool to consider. So I will share now some before and after picture from all over the world using different types of protocol. Maybe it can give some ideas to some of you. So this one is Exciplex used weekly, twice weekly, and tacrolimus. So this is the result after 17 sessions. This is one result from Vietnam to use on pediatric, once weekly plus tacrolimus. Another example from Vietnam using skin crafting and Exciplex after 8 sessions. One results from Mexico using Exciplex once monthly and bimatoprost. One results also from Mexico combining Exciplex with exosome injection. So this is only after 3 sessions. So you see the results is very fast. The repigmenting process has started very quickly. One results from India combining 3 things, Exciplex, oral mini pulse, and calcineurin inhibitor lotion. So after 28 sessions, very good results. One results from Vietnam, again combining Exciplex with microneedling and tacrolimus. So you see after 18 sessions, it's almost 100% repigmentation. And this is the results from Dr. Rodriguez from Mexico with a special protocol of using Exciplex once monthly. So you see actually the results after 6 months is only with 6 sessions. And she combined with daily application of 5-fluorouracil and clobetasol. So there are new treatment, and I'm sure you have all heard about how wonderful JAK inhibitors are doing now in the last 2 years. So actually, we heard a lot about ruxolitinib that has been the first topical approved by FDA for non-segmental vitiligo. And of course, the risk of side effects is much lower compared to oral JAK. We have also in the market tofacitinib, baricitinib, upadacitinib. So there are many variants. I think the results are really, really great. Also combined with phototherapy. To me, the main barrier so far remain the cost. Well, it depends the countries, but in some countries it's still very costly. However, I'm sure that in the coming years they will be more maybe cheaper and affordable for patients. So we have here some results combining Exciplex with tofacitinib, for example, and Minipulse. This is after 32 sessions. This is oral tofacitinib and calcineurin inhibitor after 28 sessions. This is one case from Vietnam with Exciplex and topical ruxolitinib after 18 sessions. So it's very fast treatment, actually. So in less than 3 months, you can see the repigmentation is very good. So we're going to switch now to alopecia areata protocol. So for eczema, the main indication is focal alopecia areata. Of course, it will have an anti-inflammatory effect and will promote the hair regrowth in localized patches. Also, in this case, there is no MED that is performed, and the dose is also defined according to body area. So if you have on scalp, we will start with 200 millijoule, which is 2 seconds. And if it's on the face, beard, eyebrows, etc., we'll start with 100 millijoule, which take 1 second. And again, the protocol is the same. You increase by 50 millijoule if there is no erythema, and you decrease by 50 or 100 if there is too much erythema. The session frequency is the same, 2 times per week ideally, and the average number of sessions is between 15 to 20 sessions. So I want to say the indication is focal alopecia areata. There are some doctors using on alopecia totalis and alopecia universalis. However, there is no clinical evidence so far. So some doctors have shown really good results and some doctors have been disappointed. So the main indication is focal alopecia areata. It can be combined with calcineurin inhibitors, corticosteroids, intralesional injections. So you keep on doing your injection once a month and eczema once a week. Minoxidil, food supplement like zinc, iron, etc. And also these JAK inhibitors. So the first studies actually published on the efficacy of eczema on alopecia areata is from 2004. So actually now 20 years ago. And since then, there has been about 60 studies on alopecia areata. I have put 3 examples that I find quite interesting below. One is on the efficacy on adolescents and children. So it's always good to see that it's safe on pediatric patient. The second from Thierry Passeron was about a long-term follow-up, how much relapse we have. So in this case, the results were good, that there is not more relapse than for other type of treatment. And the third one was comparing intralesional injection with eczema. So it's a very interesting study because the first line of treatment is intralesional injection. The result was that the efficacy was the same. However, it took longer with the eczema to reach the same results as with the injections. So here's some before and after pictures. So this is monotherapy. That means only eczema light was used after 18 sessions. So you see the hair regrowth is quite good. So this is only 9 weeks. This is the evolution using eczema from day 1 to 36 session using only excimer light. This is a combined treatment after 28 sessions using Exciplex twice weekly, topical minoxidil and topical corticoid once a day. And you see the hair regrowth is 100% after 28 sessions. This is a very nice case also from Vietnam. You see a quite severe condition. And in this case, they have used Exciplex twice weekly and also have done 5 times intralesional injection and also topical treatment. And this is one case from Mexico, from Dr. Galvan, using LED and excimer and erbium in this case. So you see here in 14 sessions, the result is very good. So we have got a nice study from Dr. Dalia Rodriguez from Mexico, where they assess the efficacy of this monthly protocol. So in this study, they do double stack excimer lamp. That means they will do 2 doses divided in 2 shots. So instead of doing, let's say the dose would be 500 millijoule, they will do 2 times 500 millijoule. And they combine it with clobetasol and minoxidil daily. And you can see here on the lesion that this man has on his face, it has taken only 2 months, only 2 sessions of excimer and 2 months to have a complete hair regrowth. So it's a very fast treatment. This can be a very good alternative for patients that are not able to come to the clinic twice weekly and still provide a solution for them. And this is one case from Japan, from Dr. Kakio, using Exciplex and scaric acid DBT lister. So this is also a very good result after 9 months. You can see complete full hair regrowth. And now we're going to switch to psoriasis protocol, which is a little bit different than the others, because in this case, sorry, there is a mistake on my screen. MED is performed. It's excellent for localized plaque psoriasis, especially on difficult areas. And ideally, to me, palmoplantar, because it's quite difficult to apply topical. So in this case, we will do what we call the minimal erythema dose. So you can see on the screen how it is performed. You shot 6 doses to define at which dose your patient will have erythema. And then you will start with this MED for thin lesion. And if you have a thick lesion, for example, in joint areas, you will do MED multiplied by 2. And then it's the same. If you don't have erythema, you increase, in this case, by 0.5 of your MED dose. And if you have too much erythema, you will also decrease the dose. The session frequency is 2 times per week. And the average number of sessions is 15 to 20 sessions. If you see no improvement at all after 15 sessions, it's the same. Please discontinue the treatment. This is one case from Dr. Suzuki from Japan. So this patient was not responding to a previous treatment of corticoid, was getting worse and worse. And after 21 sessions, you can see the result is really nice. I also want to say that excimer do not have any efficacy on nail psoriasis, because we can see also here on the screen. Another case combining Dagobet and Exciplex twice weekly on palmoplantar psoriasis after 10 sessions. So it's literally 5 weeks treatment. It still needs to be done, but you can see the improvement is very remarkable. one case, one case from Mexico, from Dr. Dalia Rodriguez, that is doing this protocol once monthly. So in this case, after 4 months is actually after 4 sessions, and she combined with calcipotriol, betamethasone, and coal tar 3% daily. And you can see how amazing the results are. One case from Professor Leone, that has done nice studies for us lately, where he's doing Exciplex 1 to 2 times weekly, and he's doing a narrowband cabin daily. In this case, you need to look always at the left side of the lesion, because here's the comparative studies, and you can see the improvement after 15 sessions. Again, another case, so you can see actually treating with Excimer on the left side, and the difference with only the right side. And this is one case from Dr. Letona, treating this patient after 12 sessions, treating with Exciplex twice weekly, using methotrexate 15 milligram on Sunday, and using regular folic acid from Monday to Saturday. And you can see in only 12 sessions, so 6 weeks, the results are amazing. So 1.5 months. So do we do maintenance or not? This is a question that comes quite often. We recommend to do 2 times per week until you have about 90% completed. Then you can switch to 1 time per week until you are satisfied, or you have 100% of completion of your protocol, and then you can switch to every 10 days, every 15 days, and then once every month. It's important to keep on seeing this type of patient, because still there is a risk of relapse. We noticed from various feedback that if the patient keep on using tacrolimus, the risk of relapse decrease a lot. What are the side effects that you can get by using Excimer? Of course, the main side effect will be persistent erythema. This is quite easy to handle. In this case, you should postpone the next session of Excimer until there is no more erythema. The second will be PIH, perilesional. So in this case, where the reduction tip has not been adapted to the size of the lesion. In this case, you can see, the lesion was much smaller than the reduction tip that has been used. So this is, of course, pigmentation that is epidermal, so it will disappear over time. And the worst case scenario will be blistering, especially if you're dealing on sensitive area that can blister quite easily, so genital, lips, etc. So in this case, of course, phototherapy should be completely stopped until complete healing. So how to avoid this type of side effect? Of course, use the right reduction tips. So there are 2 ways. Of course, there is reduction tips, this plastic one that can be adapted directly on the device, or you have silicone mask that can be applied on the patient's skin. There are more ways, more artisanal, handmade. So, for example, you have medical strap, as you can see. You can also put a regular sunscreen on the healthy skin. You can also use this stapler to make some little hole in paper, or you can make your own reduction tip, for example, as you can see on the screen. So, for example, Dr. Swapnil Shah, he's cutting this way, and there has been also a nice study from Saudi Arabia from Dr. Alisa showing how to make this pepper shield. Feel also free to ask your patient to do it for you. They will be more than happy to do it. In this way, this is the best way to prevent pH. So this is a small video of me doing a reduction tip. So you can see I have cut it inside a paper. So ideally it should be a cartoon paper, something that is not too thin, so it can last a little bit over time. Eczema contraindication, of course, pregnancy. Photosensitivity, children below 10 years. There are no clinical evidence on children below that years. Skin cancer, skin dermatosis Kovner, and lupus erythematosus. So why is eczema actually a very good tool for the practice? It has no consumable, it's time-saving, portable. You can take it from one clinic to another or from one treatment room to another. Can be used by staff. It's so easy. It can't go wrong. New service to the clinic, safe and painless, completely painless. So that's good, especially on pediatric also. Very efficient, especially also on resistant patches. Can treat all body areas. Periorbital, for example, you don't need a special eye shield protection. Genitals, any body area can be treated. Handy and no social downtime because you're doing a targeted treatment, so you will not have erythema on healthy skin. I'm sorry, I have a cold. And this is a map of our KOLs all over the world. So if you have one that you know it's nice, you can ask them some tips also. Sorry, and that's it for me for today. Thank you very much for your attention. If you have any question, feel free to type it in the chat, or you can also unmute yourself and ask the question.
Thank you, Cecilia. It was a very insightful webinar. I hope our participants learned a lot today. We have only one question so far in the chat, but we can expect more, I guess. The first question is, have you seen cases of exacerbation of alopecia areata with Exciplex?
So that's a very good question. So there has been some reported cases where the patient had more and more lesion. This is actually not due to the treatment itself. It's just due that you're dealing with an unstable pathology so far. Some doctors, to make it more stable, they use for a short time corticoid before starting with eczema.
Okay, thank you very much. I know we've got doctors that are also wondering at which age would you start treating a patient? I'm talking about children, of course, but what would be the starting age for you?
So as I said, the clinical evidence starts from 10. So officially we say it's 10 years old. There are many doctors using it from 4 years old, but then it's up to the doctor responsibility to take the risk or not.
Great, thank you. Do we have other questions?
Yes, please.
Perfect.
Hi, good afternoon. My name is Amy, and I'm from the UK. So I'm currently treating a patient with vitiligo, and we've had great results on the face. I think after 6 sessions or so, we've had great results on the face, and the energy I'm using currently is up to 200, and it's been fantastic. However, the challenging bit is the hands and the feet. I'm currently on 450. I've done a test patch 2 days ago on 500 and 550 on healthy skin. I'm seeing him tomorrow. Now, my question is, how high can I keep going if I'm still not getting results on the hands and the feet? If any, what other treatment can you recommend? I know you spoke about CO2 and microneedling earlier on. What will you recommend I can incorporate with my treatment to have the result my patient really wants?
Okay, so thank you for your question. So actually for acrylic vitiligo, you can start already with 400 or 450 because for acrylic you need high dose. So that's one thing. Don't worry about high dose for acrylic vitiligo. The second thing you're asking about how high you can go. Well,
Yes.
there is no maximum dose, let's say. If your patient has no erythema and you are doing 1,500, then you can keep on increasing. The key is really erythema. So if they have erythema, then you are at the right dose. And the last thing is for acryl, you need to combine ideally with CO2 or erbium, whatever you have in the clinic. And
Okay.
I don't know if you have these JAK inhibitors in the UK available yet, but if then I would really recommend to get a prescription for JAK inhibitors because for acrylic vitiligo, it's very hard to achieve a very good percent of repigmentation.
Okay. I mean, we do have CO2 in our clinic and we do microneedling as well. The JAK inhibitors, I'm not 100% sure, but I will speak to my doctor.
Yeah.
So, I mean,
If you can get the prescription, honestly, this will be the best for acryl.
okay. All right. Thank you very much. That was very interesting.
Welcome, with pleasure.
Pleasure.
Okay, so I don't think we have more questions so far. Let's wait 1 more minute, but I think
Hi,
everyone. Ah, great, Nadia.
hi. My name is Nadia
Waiting.
from United Kingdom, from Cosmetic Clinical Trainer. I've got a question for you. When you show the plastic body wrap to do the treatment for vitiligo, I'm just wondering, could it be any plastic wrap or is it a specialist product that you would recommend to use
Oh
when
no,
you?
it's a regular plastic wrap, food wrap,
Oh,
nothing special.
all right, that's great. Thank you.
You're welcome. Okay, so I think we had it all covered. So thank you all very much for your presence, for your attention.
I know
Oh,
that the webinar is being recorded. Is it possible to have a copy sent to us, please?
yes, the webinar is being recorded actually, and we'll send the recorded version maybe tomorrow.
Okay then. All right. Thank you very much.
Thank
We've
you.
got one more question as well in the chat, Cecilia, if I may. Is there an effective higher dose due to studies and no need to go higher than these dose?
Yeah, that's a good question. So there is no need, and you're right to go higher than a certain dose. It is not defined dose because this is really according to each patient. However, if a patient is not responding, let's say at 1,000 millijoule, it's better to do erbium or CO2 and excimer than doing, for example, 1,500 millijoule without any combination.
Thank you.
Okay, thank you all for your presence. Wish you all a lovely day or lovely evening according to your time zone, and hope to see you soon wherever in the world.
Thank
Thank you,
you.
Valentine.
Thank you.
Bye.